Hello, this is Dr. Biff Palmer, Professor of Internal Medicine at UT Southwestern Medical Center, Dallas, Texas. I'm going to discuss the publication entitled Use of Extended-Release Calcifediol to Treat Secondary Hyperparathyroidism in Stage 3 and 4 Chronic Kidney Disease by Stuart Sprague and colleagues. This study report was published in the American Journal of Nephrology. I selected this article to discuss the effects of extended-release calcifediol. Supplementation with ergocalciferol and cholecalciferol is recommended for secondary hyperparathyroidism. However, current guidelines do not provide guidance on how supplements should be best administered. A previous single-dose comparative clinical study showed extended-release calcifediol was more effective than immediate-release calcifediol in lowering elevated plasma intact parathyroid hormone values in chronic kidney disease patients with vitamin D insufficiency. This study extends those findings, demonstrating the safety and efficacy of 30 to 60 micrograms per day of extended-release calcifediol in the treatment of secondary hyperparathyroidism over a treatment period of up to 52 weeks, and simultaneously correcting the underlying vitamin D deficiency in adult patients with stage 3 or 4 chronic kidney disease. Before I analyze the study in more detail, I'd like to discuss, or at least highlight, some of the comments from the lead author, Dr. Sprague. When asked as to what the three most important highlights of the study were, he mentions the following. Extended-release calcifediol effectively and safely corrects vitamin D insufficiency and the associated elevations of plasma immunoreactive parathyroid hormone in patients with stage 3 or 4 chronic kidney disease, providing an attractive alternative to nutritional vitamin D and vitamin D receptor activators for treating secondary hyperparathyroidism. Number 2, the effectiveness of extended-release calcifediol in controlling hyperparathyroidism is directly related to the administration dose, the duration of treatment, the degree to which the serum 25-hydroxyvitamin D is raised above 30 nanograms per ml. He also notes that extended-release calcifediol has minimal impact on serum calcium, phosphorus, fibroblast growth factor 23 levels, and on urine calcium, suggesting that it does not raise a patient's risk of extraskeletal calcification. When I asked what impact do you think this study will have on the management of patients with chronic kidney disease, MBD, the present treatment paradigm for patients with CKD stage 3 and 4 has been to use nutritional vitamin D, that is cholecalciferol and ergocalciferol. And then if hyperparathyroidism persists, one would add an activated vitamin D like calcitriol or an analog. He comments that this regimen has not been demonstrated to be effective without increasing the risk of hypercalcemia and/or hyperphosphatemia, as well as increasing FGF23 levels. In fact, the proposed revised KDIGO guidelines for CKD-MBD comment on the ineffectiveness of nutritional vitamin D and recommend against the routine use of calcitriol or one of its analogs. Thus, as he mentions, these suggest that extended-release calcifediol could become an effective therapy to treat and prevent vitamin D deficiency and hyperparathyroidism in our pre-dialysis patients. So let me go ahead and discuss the methods in more detail of this study. The study involved two identical, multi-center, randomized, double-blind, placebo-controlled trials across 89 U.S. sites involving adult patients with either stage 3 or 4 chronic kidney disease, secondary hyperparathyroidism, and vitamin D deficiency. Eligible patients were randomized in a 2-to-1 fashion to receive oral extended-release calcifediol at 30 or 60 micrograms or a placebo once daily at bedtime for a 26-week period. 298 or 69% of eligible patients were then entered into a subsequent open-label extension study wherein extended-release calcifediol was administered without interruption for another 26 weeks. Plasma immunoreactive parathyroid hormone and serum calcium, phosphorus, and total 25-hydroxyvitamin D were measured every 2 to 4 weeks in studies A and B and in the subsequent extension. The primary efficacy endpoint in all three studies was the number of patients in the intent to treat population that attained a mean decrease of greater than 30% in plasma immunoreactive parathyroid hormone from pre-treatment baseline in the efficacy assessment period. So what were the key findings in this study? Well, 429 patients were randomized, 213 subjects were randomized in study A, 72 received placebo, 141 received the extended release calcifediol, and in 216 patients were randomized in study B, 72 of whom received placebo, 144 received the study drug. 354 subjects, or 83%, completed both studies A or B. The mean age of the patients was 66 years, about 50% were male. No significant differences were detected among the two treatment groups for both the individual studies A and B and for the pooled data. At baseline, the mean estimated GFR was 31 mLs per minute. Mean plasma immunoreactive PTH was 130 picograms per ml for subjects with stage 3 disease and 166 picograms ml for subjects with stage 4 disease. Mean serum calcium was 9.2, mean serum phosphorus was 3.7, and the mean serum total 25-hydroxyvitamin D was 20. Mean serum total 25-hydroxyvitamin D increased gradually and compared with the extended release calcifediol treatment in both studies, but unchanged with placebo treatment. Levels remained stable throughout the 52-week period. The most common adverse events were urinary tract infection, diarrhea, and hypertension. Adverse events observed more frequently in the extended release calcifediol subjects versus placebo subjects were anemia, nasopharyngitis, increased blood creatinine, and dyspnea. The extended release calcifediol increased serum total 25-hydroxyvitamin D at a slower rate than the immediate release formulations and normalized serum total 25-hydroxyvitamin D concentration to a value greater than 30 in greater than 95% of per protocol subjects, while reducing plasma intact parathyroid hormone values by at least 10% in 72% of the subjects. The extended release calcifediol may provide a more reliable and standardized approach to vitamin D repletion than any commonly used regimen of nutritional vitamin D. So what are my thoughts of this study? Clearly, nutritional vitamin D, as we use it today, poorly restores levels of 25-hydroxyvitamin D. Calcifediol is a prohormone of the active form of vitamin D3, and the extended release form of this compound seems to be more effective in lowering parathyroid hormone and restoring 25-hydroxyvitamin D levels than what we utilize today. It is quite likely that this type of a compound may begin to be utilized more commonly in our stage 3 and 4 chronic kidney disease patients, but is unlikely to be effective in our chronic kidney disease stage 5 and is not indicated for use in that population. Does controlling parathyroid hormone level at CKD stage 3 and 4 lead to outcome benefits? This is a question that is currently not known, but would be worth examining now that this type of an agent is available for clinical use.